which is the biggest problem we have today in implant and in perio? Proximity. This is our nightmare, yes? Proximity is our nightmare, both when we treat gingival recession, when we treat bony defect, if there is no soft tissue at all, we have to extract one of the teeth, but also around the implants. So if there is proximity, this is the most challenging situation. And we cannot solve all cases in which there is proximity. Let's start with root coverage. You see, this is an incredible, difficult patient. And this is despite the level of attachment and the level of the bone is perfect, you know? It's not a matter of attachment level, the determining factor for achieving complete coverage or not is the proximity of the root. And when I speak about proximity, it's not only that the two root is too close, but you can see how much this soft tissue, this papilla, is palatally displaced with respect to the amount of avascular surface that you want to cover. This is a case in which there is no way to achieve complete coverage. There is no way, because it's too unfavorable. The ratio between vascular bed, coronal to the cementoenamel junction, and avascular surface to be covered. And then there is something that we can do surgically in order to optimize the outcome that can never be 100% of root coverage. So what can you do in a case like this to, let's say, surgically compensate as much as possible the proximity between the root? This is the best. No, if you try to reduce this, you go to the pulp before there is a significant increase in the vascular bed, you know? So theoretically, the only thing that you can do is work orthodontically. But work orthodontically means that you obviously have to change completely the patient mouth in order or to extract one tooth. If you extract one premolar, this becomes perfectly coverable because this becomes an dental site, so the vascular compared to the avascular becomes favorable, but you have to extract one premolar. And most of the patients are not happy. So this is the maximum amount of coverage you can achieve in a case like this, that if you look at carefully is not complete. Here there is the cementoenamel junction that is exposed, and here there is the cementoenamel junction that is exposed. But look now, this papilla, it seems to be another patient. So it's a great outcome, which is not 100% coverage. So what can we do surgically? First of all, we have to use a trapezoidal approach with no doubt, because the only way for this papilla, for the papilla that we create between the two adjacent teeth to advance coronally and take 100% of the blood supply coming from the anatomic disepithelialized is if you use a flap that goes straight full. So no oblique incision, no multiple, no envelope type of flap. Otherwise, this papilla cannot take the advantage of receiving the greater amount of blood supply. So trapezoidal flap approach is mandatory. And obviously, you can work at the level of the two adjacent papilla as much as possible, making them even wider than the 3 millimeters. So the flap here remains very stable because there is a lot of blood supply. The flap remains stable, and this can help the stability of the flap also in the area of weakness. Where you make the horizontal incision should be in keratinized tissue. So you have to leave at least 2.5, 3 millimeters of keratinized tissue, but the more apical you can. Because the more apical you go, the wider becomes the horizontal incision. But you cannot go more apical than here because otherwise there is no keratinized tissue in your papilla enough to be stabilized above the anatomic disepithelialized papilla. So work on this. Now elevate this papilla, trying to maintain as much as possible a good thickness during this papilla elevation, using a very, very small needle for the shape, but as soon as you are able to elevate the angle, use the thinnest blade you have in order to maintain this papilla so small, but very, very, very thin of uniform thickness. So this is the papilla elevation in this particular case, which is an exception because of the very, very big avascular surface. Now, what you need is a flap that is so free to be advanced coronally that this papilla is so free to join with the anatomic disepithelialized papilla without any tension. And this will be the last one, obviously, to be stabilized once the adjacent papilla already stabilized the flap in the coronal position. Now you have to remove the whole submucosal tissue like we do in the lower incisors, because in this patient we don't have to leave any muscles, any submucosal in the periosteal bed in order to provide the best verticalization of the flap to the periosteal bed. So like you are treating gingival recession in the lower incisors. So remove the whole muscle submucosal tissue from the periosteum, especially apical to this very, very weak papilla. Now, disepithelize this papilla the better you can. The invitation is done with a blade, and then you have to buy the right microsurgical scissors that allow you to complete the disepithelialization towards the tip. Despite this papilla is extremely small, you cannot leave remnants of epithelium that don't provide any blood supply to the surgical papilla of the flap. Vascular bed, yes? Now, when you fix the connective tissue graft at the level of this papilla, you cannot use the single interrupted suture. Since this papilla is so palatally displaced, if you make a single anchorage, the risk is that the graft goes too much coronal and you don't leave enough vascular bed for the surgical papilla of the coronary advanced flap. So you have to use the same suture technique that we use around implants, remember? So graft, full thickness perforation to the palatal aspect. So you use a 8 millimeter long needle, not 6. Take the suture from the palate, perforate the palatal aspect with the mattress suture. You have to see the needle getting out here at the base of this papilla, just a bit coronal to the graft, so you can close and leave this area completely untouched by the suture. So I perforate the palatal aspect. You have to see the needle getting out here, just coronal to the graft, and now close the surgical knot so you don't risk to displace your connective tissue graft too much coronally in this papilla that it's so weak, so palatally displaced that don't allows you to place the graft more coronal than this. And obviously, you have to block the graft at the base of this papilla by fixing the surgical knot onto the graft. And you see that despite the graft is very, very nicely applied to the root, there is still the vascular bed of the entire anatomic disepithelialized papilla that is available for the surgical papilla of the flap. Now, you have to close the vertical incision, you have to close the surgical papilla, and then the last one is a papilla closure that is not a sling. Why? Because if you sling, there is the tendency of the suture to go or mesial or distal, and this is a papilla that is too small to be sling. So you have to make a single interrupted suture that makes the base of this papilla full thickness to the palatal aspect, coming back and close. So we need the 11 millimeter long needle, full thickness perforation to the palatal aspect once the flap is already stabilized at the level of the two adjacent papilla. Take anchorage in the palatal aspect with a mattress suture. Go back below the contact point or above the contact point and close. So this is a very, very site-specific compression of the surgical papilla above the anatomical papilla at the base, with no risk that during the sling, this suture can be moved or mesial or distal. So you need a compressive suture in the middle. So there is something that you can do during the flap design, during the flap elevation, during the sequence of the suture, in order to improve the coverage. But as I told you before, so stabilization of the graft, and this is the healing, which is very good. But if you look at carefully, not all the root is completely covered. Here there is about 1 millimeter of remaining gingival recession, and most probably there is 0.5 years. So when you judge this, it's not a complete coverage, but it's not a case that you can try to do something more.